time at the end to answer any questions that you have. So I just wanted to review the objectives today. So first of all, we want you to be able to understand that the presence of weight stigma in the healthcare setting and understand what it is, and then describe the cycle of bias and obesity. Furthermore, we hope that we'll be able to give you information to understand the importance of word choice, office environment, and workflows in
To connect to please and you will now read.
I think that we have technical difficulty. I think that the folks that are listening over the computers are having trouble hearing, so give us 1 minute. Actually, we're back on. So again, shame does not motivate change. It does the opposite. It contributes to behaviors such as binge eating, social isolation, avoidance of healthcare, decreased physical activity, and increased weight gain over time. So stigma, in fact, increases the barriers to change and leads to increased rates of obesity. And so the cycle of bias, I think this is a great visual of what is actually occurring. And so if the patient with obesity has obesity, there are increased risk for health consequences, and these drive them to increase medical visits, in which, and at those visits, they are likely to experience bias in healthcare. This leads to negative feelings that then leads to avoidance of future healthcare interactions with the clinical setting, and then worsening unhealthy behaviors and poor self-care, which then in turn lead to worsening obesity. And so weight stigma is much like disease stigma that has been demonstrated in population health in the past. And so we know from other examples such as HIV/AIDS, various cancers, alcoholism, and drug use, stigma can have a significant impact on our ability to affect change within that disease. We know that stigma, and weight stigma in particular, is prevalent in numerous settings, and it affects health and success of individuals both personally and socially, as well as educationally and professionally. And stigma itself is a barrier to prevention, intervention, and treatment. And so acknowledging stigma and addressing it in our clinical settings is an important step in addressing the obesity epidemic in our society. And so let's talk a little bit more about the extent of weight stigma in multiple settings. And so we know that weight stigma is present from very young ages. Studies have demonstrated that preschoolers attribute negative characteristics to their peers with overweight or obesity. Additionally, there are further studies that have shown that older students are less likely to offer help to their peers with overweight or obesity. There's increased rates of victimizations, increases with the student's BMI. And weight has also been identified as the primary reason students are being bullied at schools. One other study identified that 71% of adolescents seeking weight loss treatment report being bullied about their weight in the last year. So the vast majority of youth that are impacted in that study with overweight or obesity were experiencing weight stigma. Additionally, many of the studies are indicating that students may not experience this on a limited basis, but it persists over a series of years. So kids are experiencing weight stigma and weight bias from their peers at school, but they're also experiencing it from the educators at school. Educators have identified that bullying in the classroom is one of the most problematic forms of bullying that they experience. So other peers bullying their classmates because of overweight or obesity. But it's also been shown that educators themselves exhibit weight bias and stigma. They have lower expectations of their students with overweight or obesity in regard to physical, social, and academic abilities. And they may show and exhibit negative weight-related stereotypes and beliefs as well. So it's not only the peers that children may experience weight bias from, but also their teachers in their classrooms. Furthermore, parents may be exposing children to weight bias in the homes. They do identify that it's the most common reason that youth are being bullied is because of weight, but about 37 to 53% of children report being teased or bullied by the parent themselves. So not only are children experiencing weight bias in their schools from their peers, perhaps from their teachers, perhaps in their homes by parents or siblings, but also there's been a lot of research looking at what is the prevalence of weight stigma within the media that children are consuming. We know that screen time is a difficult issue for many kids, and I think recent statistics have shown that the average amount of screen time that children consume is over 4 hours a day. And so studies looked at children's movies in particular and found that 70% of these movies include weight-related stigmatizing content. And 90% of that stigmatizing content targeted the characters with obesity. Furthermore, they looked at youth-targeted television shows, which found that about 50% of these shows contain weight stigmatizing content. And that's versus about 38% of the shows that target actually the general audience. Many times, characters with overweight or obesity or larger body sizes can be portrayed as aggressive, unpopular, evil, unhealthy, and can be the target of ridicule or humor. And so next time you're watching TV, kind of open your eyes to this. And once I read this information, it was amazing how frequently it actually does occur. And then not only are kids experiencing it at schools and in homes, on the media that they're viewing, but also in healthcare. Healthcare providers, dietitians, psychologists, medical students, and nurses all have been documented to exhibit and expose our patients to weight stigma and bias. Patients have been reported with a number of negative, healthcare providers have been shown to hold another number of negative views about patients with overweight or obesity in a number of different studies. And I think this slide is nice because it really it explains the various settings that people are reporting that they're experiencing weight bias. So this is a study of about 2,500 women with overweight and obesity, and they were asked if they'd ever experienced weight bias from this various list of sources. And you can see that about 69% of this group reported that they had experienced weight bias from their doctors, about 46% from their nurses, 37% from their dietitians, and 20% from mental health professionals. But they'd also experienced it in multiple other studies like we've just discussed. 3/4 had experienced weight bias from family members or classmates, friends and co-workers. About 43% had experienced weight bias from their employers. And then if you look at the second column, it really reviews did this happen just once or multiple times? And the vast majority of times it's happening more than once. So what are the consequences of experiencing weight stigma and bias? So studies have looked at and have shown that patients who experience weight bias and stigma are more likely to experience social isolation. Greater than 2/3 of kids who perceive themselves as having excess weight actually believe that they would have more friends if they could lose weight. Not only does it affect their social interactions, it also affects their academic outcomes. It's been shown that bully victims, in particular victims of weight-based bullying, have exhibited declines in grades and have also exhibited school avoidance. And the prevalence of these symptoms is increased per teasing incident. Furthermore, it can lead to unhealthy eating behaviors. Binge eating prevalence increased among children who had been teased based on their weight. Additionally, rates of emotional eating were increased. There's a long-term association with weight-based bullying and disordered eating, and these relationships are linear. So the more stigma and bias incidents that children were exposed to, the greater their rates of these conditions. Additionally, it can lead to decreased physical activity. More frequent teasing has been shown to be related with decreased activity levels. They have less self-confidence in their physical abilities, lower levels of physical fitness, and additionally it leads kids to perhaps avoid physical education class in school and other school activities. And it's again been shown that about 85% of high school students report witnessing weight-based teasing toward their peers during gym class, so just the class that all of children are given an opportunity for increased physical activity may be the place where they may be experiencing it most frequently. Furthermore, it's been shown that weight bias leads to worsening obesity. Girls who experience weight stigma had a 65% increased risk of developing and or worsening overweight or obesity. The odds were greater if the stigma that they experienced was actually coming from family members than it was if it was necessarily coming from friends or teachers. And these outcomes have not been just demonstrated in the short term, but a longitudinal study demonstrated that weight stigma had predicted higher BMI and obesity for both women and men in a 15-year longitudinal study. So we talked a little bit about what weight-based bias is, where children and patients may be experiencing this, some of the consequences of the weight stigma that they're experiencing, and let's look a little closer about the clinical impact of weight bias that patients may be experiencing when they're in our healthcare clinics. So we know that parents and children with obesity may feel blamed or dismissed. Additionally, it's been shown that patients with obesity are less likely to obtain preventive health care services and are more likely to cancel appointments and delay care. So it can also impact not only the patient's feelings about the clinical interaction and their likelihood of showing up, scheduling appointments in the first place, and following through with appointments as well, but also has been shown that it is affecting the care that we as healthcare providers may be providing. Some studies have shown that healthcare providers are more likely to spend less time and engage in less discussion with patients with overweight and obesity. Furthermore, there can be a reluctance to perform preventive health screenings, such as pelvic exams, cancer screenings, and mammograms. A different study looked at mental health providers, and it was shown that they were more likely to ascribe more pathology, more negative and severe symptoms, and worse prognosis to patients with overweight and obesity. Furthermore, at times, clinics do not provide appropriately sized medical equipment, And this can affect not only the quality of care, if we have an inappropriate sized blood pressure cuff, the accuracy of that measurement is affected, but also the patient's experience of their interactions in that clinic setting, which then in turn affects their likelihood to return and their feelings while they're there at the clinic. So some examples of weight bias in the clinical setting. Patients have described disrespect and negative attitudes that they've had from providers during discussions or interactions in the clinic. Patients may experience embarrassment of being weighed in a public area. They've described issues with inappropriately sized medical equipment or the problems that arise when they present to clinic and the appropriate sized equipment isn't available. And additionally, they've described unsolicited advice to lose weight, so they may present with an unrelated problem and they feel like the focus is shifted to their weight and they're given advice that they're not seeking at that time. Additionally, it's been shown that weight bias can have psychological effects on patients. It's been shown that rates of depression, anxiety, substance use have all been increased in patients who have experienced weight bias or teasing, and that's when it's corrected. So patients who experience teasing and have an elevated BMI compared to patients with an elevated BMI who have not experienced the weight bias. And those rates are higher in that group that have experienced the stigma. Furthermore, low self-esteem and poor body image have been linked with increased episodes of teasing. Additional studies have shown that there is a link between weight-based bullying and self-harm behaviors, suicidal thoughts, and suicide attempts. One study revealed that the odds are 2 times greater of thinking about or attempting suicide among children who are teased about their weight compared to those who are not. So after looking at the consequences of weight bias, some examples of it in the clinical setting, and the impact that it has on the care that we provide and the patient's experience of care in our offices, what can we do? What can we do to address the stigma in the clinical setting? So recommendations are that we identify what personal attitudes we have. Awareness is really our first step in change, and so identifying any personal biases we may have is a great place to start. There are a number of self-assessment tools that are out there, but many of them ask questions similar to these. Do I make any assumptions based only on weight regarding a person's character or other qualities? Am I comfortable working with patients of all sizes? What feedback am I offering to patients to encourage healthful behavior and change, and how am I doing that and presenting that information? Am I sensitive to the needs and concerns of patients with obesity? And do I treat the individual or only the condition? And do I keep those two separate? So one thing that's an important place to start after if we think about what personal biases we may hold, it's important to realize that obesity is a factor of many, is a product of many factors. It's a really complex medical condition that's mediated through the interplay of multiple factors: genetics, biology, metabolism, behaviors, as well as our social, economic, and cultural determinants. And I like this graph because it really displays this socio-ecological model, and it talks about the child as the center, and all the factors listed in that darker oval in the middle really are the factors internal to that child that affect the likelihood that they may have issues with overweight or obesity. They include genetics, nutrition, how rapidly did they gain weight early in their infancy or in their interuterine environment, what's their gender, race, and age. All of these factors go into play, but also important are to consider the family factors that the child is surrounded by. What's the parent's health and weight status? What media is the child being exposed to in the home? What parenting education or parenting skills or lifestyle is the child exposed to? Is there any trauma that this child and family is experiencing, domestic violence, or is there financial or other stressors that are impacting the biology and the environment of that child? And then further, there's the community in which we're all surrounded by. So how well does that community that supports that or surrounds that child and family, how is it addressing the ability for children to experience physical activity in schools on a daily basis, and the nutrition that the child is exposed to at school? What are the policies the school has in place to support wellness and promote healthy attitudes and behaviors towards food and physical activity? And what access do patients and children have to health and nutrition? So all of these factors come into play. So it's a complex disease state, and it's important to remember all of these factors, and there's not one simple answer to correct the problem. The other thing that's important to consider is many patients, as we've just shown, have previously experienced bias in the healthcare setting, so being sensitive to any negative experiences that they may have had before, and if they're defensive or having kind of a defensive attitude, perhaps that's just a protective mechanism for what they've been through before, and so being sensitive and empathetic to that response. Also, it's important to emphasize our concern for their health and focus on behavior change rather only on the numbers that we're seeing on that growth chart. Finally, it's important to realize that many patients have tried to lose weight or change behavior repeatedly, and acknowledge that they may have tried many things that you may be initially suggesting to them. It's important to acknowledge that behavior change and lifestyle changes are extremely difficult, and to be able to provide as much support as possible in our brief interactions in the clinic. Furthermore, it's important to recognize that small weight loss or behavior changes, even though we're not seeing differences on that growth chart, can result in significant health gains and avoidance of comorbidities. It's important also to think about what behavior change counseling skills we're using in the clinic. Many of you may be familiar with motivational interviewing, and there's a lot of data to really support this as the gold standard of how to interact with patients when we're talking about behavior change, whether it be behavior change around healthy, active living, or substance abuse, or smoking. It's all types of behavior change. There's a lot of data to support this as an effective way to engage families and patients in these conversations. Motivational interviewing is a patient-centered and empathetic approach to behavior change, and it really focuses about a collaborative engagement between the patient and the provider, and really helping guide the patient and family in determining their own goals and addressing barriers and as to how they will achieve the goals that they've set. Additionally, it's important to think about what words you're using during these discussions. It's been shown that asking for permission before we even broach the topic is a great way to exhibit our respect for the patient's autonomy to make the decision of whether or not this is a topic they're ready to discuss. It's important, too, to use patient-first language. As with many other diseases, it respects that the patient is not the disease. So patients, it's not necessarily an asthmatic patient, it's a patient with asthma. And so using this for obesity and overweight is important as well. So a patient with overweight or obesity, it's not an obese child or overweight child. And when we're having conversations with the families, there's been many studies that have documented that certain words resonate better with families and are less offensive. And these include discussing weight or growth, talking about your child is gaining weight too quickly or gaining weight more quickly than they're gaining height. Talking about BMI is better accepted, or discussing an unhealthy versus a healthy weight. and trying to avoid words such as listed on the right-hand column there, fat, obese, overweight, heavy, and chubby have a lot of negative connotations that can turn the conversation and in that office pretty quickly. It's important also to ensure that we're providing appropriate care. As has been mentioned earlier, there are some studies that show that when a patient with overweight or obesity presents to an office, sometimes the actual cause of their presenting factors can be attributed to their overweight or obesity when it actually is not related to it at all. So explore all causes of their presenting problem, not just their weight. It's important to screen for all comorbidities. There's a lot of focus on screening for comorbidities of overweight and obesity, such as diabetes, high blood pressure, hyperlipidemia. But also remember the emotional comorbidities of experiencing weight stigma that we discussed earlier. So it's important to incorporate into your workflow or screening questionnaires, questions about bullying, self-esteem, poor school performance, and school avoidance. One way we do this in our clinic is we have a special review of systems form that we give to kids with an elevated body mass index, so that it's standardly given. We standardly give patients a way to express and to standardly screen all the patients more efficiently for the presence of any of these conditions. What about our office environment itself? So it's important to take a good look at your office environment and make sure you have appropriately sized patient gowns, exam tables that will support the weight of the patients that you see regularly, blood pressure cuffs and speculums if you're doing OB and gynecologic exams, as well as scales. Furthermore, it's important to assess the attitudes of the staff that the patients are encountering, even right from the front desk staff. Looking at the arms in the waiting room and in the exam room, are there arms? Or looking at the chairs in the waiting room and exam room, are there chairs that don't have arms that can comfortably support patients of all sizes? Is there adequate spacing between the seating in the waiting room and exam rooms? It's also important to think about the posters and the reading material that you have in your exam rooms and waiting rooms. Are any of those materials exhibiting weight stigma in the images that they're using? And we'll talk a little bit more about that soon. So not only do we look at our office environment, but also our workflows. So being weighed in the healthcare setting can be a stressful experience, and so ensuring that it takes place in as private of a location as possible is really important. Also, what words are your staff using when they're taking a patient to check their growth? So focusing on, in children in particular, that we're checking your growth, we're checking your height and your weight, but not necessarily focusing on using those words that we're checking your weight. Allowing patients the opportunity to and permission to not see their weight. Some patients don't like to see their weight, and that causes a lot of stress, and they're much more comfortable if they have an opportunity and it's standardized that they don't need to see their weight. So you can stand facing away toward or away from the scale, so giving that permission. Also, it's important that staff record measurements without making comments in the more public area if that's where if the weighing and measuring is taking place. If patients and families ask about the results of the weight, having a standardized response for staff, such as your provider will review your child's measurements and any concerns you have during your visit. If they start to initiate those discussions in the more public areas of your clinic. It's also important to think about our clinical documentation. So what patient education material are you distributing to your patients? and evaluating that for what terminology they're using. Are they using obesity or overweight? And what are your thoughts about your patient's response to that? Are there alternatives that you can use that might be better received by your families and patients? Also think about the workflow. So when you're documenting in the clinical, if you're documenting in front of the patient and they can see your screen, many times for billing and coding purposes, you have to document obesity or overweight, and can they see those terms? And how do you address that and approach that in a sensitive manner? Additionally, sometimes if we use Epic in our clinic, and so in my after visit summaries, if I've added obesity to their diagnosis list, and if I don't unclick the little box that says share with patient, that is printed on the after visit summary that they're presented with. And so in IGEN in general, it lists their BMI, and we've discussed it in the clinical setting, and so unchecking that box allows them to not have that label placed on their after visit summary. Furthermore, the policy statement, so we've talked about what things we can be doing in our clinic to change the weight stigma that our patients might be experiencing, starting from the words that we use, the approaches that we use in the office setting, the environment we surround our patients with, looking at chairs and scales and the materials that we present to our patients and display in our offices. Those are all great things that we can do to minimize the impact of weight bias and stigma and limit our exposing our patients to that in our clinic. But what else can we do to contribute to more broadly to this issue of weight stigma that's so prevalent in our communities? There are opportunities to partner with schools to share the information I've just shared with you about weight stigma and the impact that it has and the prevalence of it within schools. There are opportunities to advocate with media about promoting more positive images of patients with overweight and obesity. The policy statement also recommends that we have increased provider training on this for practicing clinicians, as well as incorporating it into our medical school curriculum and residency training programs. And then how do we share this information with parents who, like we talked about earlier, may be exposing their children to weight bias as well. Additionally, which we didn't call out specifically, but I think all of us have seen siblings who are exposing their siblings to weight bias, and how do we give parents tools to address that as well to minimize that impact. So on the bottom of this is again the citation for the article, which is we've reviewed a lot of the information in there, but it's a great resource if you want to look back on that for additional details. I just want to share a few more resources before we finish up and ask for any additional questions. There's a great resource that is for guidelines for media. So with a lot of the work that we've been doing around 5210 and addressing this more effectively in our clinics, we've also had the opportunity to share this with our public relations department when they're asking us for stories about obesity or overweight, and so to make sure that they're familiar with best practices to minimize weight stigma that we might be actually promoting when we're pushing out information from our healthcare systems. So there's a great resource that's been developed by the Obesity Action Coalition, Obesity Society, and the Red Center for Food Policy, and that Red Center is really a leader in a lot of this work on weight bias and stigma. And they have guidelines for portrayal of individuals and images of individuals affected by obesity. So they recommend that we respect diversity and avoid the stereotypes that we've just discussed. We're sensitive to the language you're using and the terminology we're using. We're balancing the coverage that we're providing and making sure it's accurate coverage of obesity and the issue, and we're choosing appropriate pictures that show children with overweight and obesity being active and eating healthy, and don't always portray them as making unhealthy choices, because we know there are many children that are making appropriate choices and are still struggling with overweight and obesity. This is just a screenshot of the guide itself, as well as the link to the website where you can download a copy of that. Additionally, there's some great resources for parents. So this link will take you to the Rudd Center, and they have a great website to help parents deal with weight bias and bullying that their children might be experiencing in schools, and how do you help give them tools to advocate more effectively for their children. There's also a great brochure that's on the Obesity Action Coalition website about weight bias in healthcare, and it's a great overview of a lot of the information we've just discussed, and so we can get you a link to that too if that'd be of help. So let's just review. We started off by discussing the definitions of weight bias and stigma, and understanding that it's prevalent in many settings as well as in our healthcare clinics. We've looked at the cycle of bias and obesity and understand now that shame is not a motivator of change, and that weight bias in actuality will lead to increased issues with obesity. We've looked at what we can do in our clinical setting, understanding the importance of word choice, our office environment, and our workflows, and perhaps have some ideas on how we can minimize the weight stigma that our patients might be exposed to. And finally, we talked about the importance of advocating outside our clinic and partnering with our schools and our communities to address weight stigma more broadly, as we do know it affects so many different sectors in which our children live and learn. So with that, I'll kind of wrap up the content section of the webinar and address any questions that anyone has.
Dr. Gross, if you have any questions, please write them in the that will be made available on the IMS Childhood Obesity website. So we will be putting up this week's webinar and the one from March 8th later this week. So those will be available to you. All of the site coordinators received an email that has information about the CEUs and CMEs to fill out the attestation form and return those to Care of Island at the Iowa Medical Society. And those need to be back by Friday, March 30th to receive credit. Anyone who is not a physician or a nurse that would like to get a certificate of attendance, please fill out that attestation form as well, and we will get one out to you. Okay. It doesn't look like we have any questions, so I will go ahead and let Dr. Gross finish up.
Sounds great. Well, thanks so much for your time today. If you guys have additional questions or need additional resources, please reach out to me. My contact information is at the end of the webinar, and you can get a hold of us by contacting the IMS and ask Rebecca, and she can get you to me as well. But thanks again for your time. Have a great day.